I need to get one of those cool LED backgrounds too. How do I get one of those?
You do. We can hook you up.
Someone needs to hook me up. Honey hasn't hooked me up yet, so someone should.
We can totally get you hooked up. Welcome everyone to Peptides Unlocked. And this is just a really quick disclaimer before we start anything. This is for education only, not medical advice. We're not diagnosing, prescribing, or giving personal dosing guidance, and results vary. Always check with your licensed healthcare provider for what's right for you. We got done with that part. And now I want to introduce to you our guest, and he's a special guest, and I have watched him on Instagram, and I'm sure a lot of you guys have also. His name is Dr. Jason Pencek. And I have a little write up about you, but look, I had it on my phone and it disappeared. So here's my backup, just like I said.
I'm
No,
dying.
welcome, Dr. Jason Pencek. You are a board certified nurse practitioner and a chiropractor.
Mm-hmm.
And you specialize in regenerative and longevity medicine from
Mm-hmm.
peptide and hormone therapy for GLP-1 based treatments for weight and metabolic health. And you're just a guru. And the first time I saw you on Instagram, I completely was drawn into you because you explain it. You're so knowledgeable, but you also explain it to people like me that a year ago, I did not know what the word peptide even meant. So thank you. And I know
I thought it was just the blue eyes, but I'll take the rest.
That's right. So thanks for coming on here. I know you're really
Of course.
busy. So we have a boatload of questions. Again, I wrote them
Great.
down. Some of them, and people can raise their hand too and ask a question. But the
Yeah, of
very
course.
first question I have is, can you explain to us what a peptide is?
Of course, the basic easy one. They throw me a
Yep.
softball. I love it. So, peptides, think mini proteins, right? This is what we're thinking. These are basic amino acids being built together. So, a protein, which we all, I think, understand what a protein is, you eat proteins to build more muscle mass and everything else. And what happens is a certain number of amino acids, these building blocks put together, we make a peptide. So, two amino acids put together, and you have a peptide up to technically 40 amino acids. It's the standard definition of a peptide, though there are some disagreements on where that number is, and it becomes a protein. Now, the way a peptide works and what a peptide is, think it's a cell-to-cell signaling molecule. So when I tell you cat, you understand what the word cat is. That's one single amino acid, cat. But you don't understand how it's being used. When I say, see that cat in that tree, now you know what to do with that. That's a signal to do something. So when you put these amino acids together in a sentence, basically in a form, now that tells your body what to do with it. So there are peptides for everything. I always joke that there's a peptide for anything and everything out there. You want to build more muscle mass? We have a peptide for that. You want to get your libido turned up? We got a peptide for that. You want to be more tan? We have a peptide for that. You want to recover? We have a peptide for that. There is always something we can do with these peptides because, again, they are cell to cell signaling molecules. They're going to signal your body to do anything and everything under the sun. And there are lots and lots of options out there. LEMD has a few peptides, but there are many out there. In fact, there's a pretty common peptide that most people understand. It's called bactracin. Most of us have probably used this. It's used in wound care. It's used as an antibiotic. It is a peptide. Glutathione, it is a peptide. Insulin, it is a peptide. So there are lots of peptides we've heard about and known about for years and years and years. In the longevity space, there's probably 50 to 60 different peptides that I use in practice. And again, there are thousands and thousands of peptides that exist. There are lots of peptides that we don't know are peptides, but they are actually in peptides in general. So I want to remember peptides is this in building blocks. And I want to remind people, peptide medicine, we talk about this stuff, people get very confused, right? NAD, not a peptide, but yet still thought of in the peptide space. So again, we use peptide space with longevity mixed together. So anytime we talk about peptides, I use it interchangeably because NAD is a B vitamin derivative, but not really a peptide. Methylene blue, not really a peptide, but also used in longevity space. So peptides in general has become ubiquitous with anything that comes to longevity and wellness in general. We just take peptides as this general term. Not that we know understanding these aren't all peptides, but I think it's just become that word that's like peptide. If you offer peptide medicine, you're working on longevity, right? I think that's kind of where we're all at now.
Done. It's over. But no, thank you. Well, so what do you say to someone? Now I'm not even going on script here, but
Yeah.
what do you say to someone when they say, I wouldn't put anything in my body like that, only natural? We hear that. from people.
Hmm. People
What?
say that to you too, not just me. It's not just me. Oh gosh, I feel so bad for all of you. It's a rough one. So I will say to you, many of the peptides are natural. BPC-157 was naturally found in our guts. It was synthetically made into BPC-157. It was gastropentopeptide 5, if I'm correct, and it was in stomach acid. What did it do to the stomach acid? It repaired the gut lining. Guess what? That acid is very bad for our bodies. It doesn't do well with us. It destroys everything. So it can destroy the gut lining. What do you want to do? You want to keep that repair going. So always repair and keep inflammation down. BPC-157 is known for repairing and recovering tissue, cartilage, can help with bone improvement. It does a lot of things. So it's a naturally occurring product in our bodies that we can do lots of things with. So a lot of the peptides we use, even GHKCU, our favorite skin, hair, nail peptide. If you haven't taken the beauty peptide, you should try it. It does improve skin, hair, nails, but we naturally make the copper peptide. It's found in our bodies as GHK, and then it binds to a molecule of copper and becomes GHKCU copper. So we have that in our bodies naturally made. It's been there. So when people worry about taking these things, fear is obviously what happens if I take this stuff long term? What's going to happen to my body? Am I actually hurting myself? Well, a lot of the stuff is natural. GLP-1s, for example, these are GLP-1 receptor agonists. We make GLP-1s. There are products on the market that are increasing GLP-1s. Acromantia and Calocurb are two products that exist that are oral. Here's the thing about natural GLP-1s. I can increase your GLP-1. In fact, Calocurb does 6x the GLP-1 that you are making, but these GLP-1s last for seconds. So what we're giving patients is just going to last longer, right? What we're doing is making the GLP-1 that we naturally make last longer in our body and a lot more of it. So we get all these metabolic benefits that we see. Weight loss for me is always the last thing when it comes to GLP-1. All these other benefits like longevity, reduction of heart disease, type 2 diabetes, Alzheimer's, Parkinson's risk, it's what I care about. So when people get to this, it's not natural. Well, it is really natural. Most of these things we're doing, they are very natural. There are very few synthetic peptides that exist out there. A lot, at least I should say, in this longevity space, there's more natural ones than non-natural. So again, I think I have to be very clear. What's the difference for most people is it's injections, right? I think that's the fear. It's not, if you told people everything we gave you was oral, I bet you anything, the cell would be so much easier. Hey, it's an oral pill. You take it and you're going to lose weight. Sure, done. No questions. It's that injection that scares everyone, right? So now I'm thinking injection. Wait, why can't I take this orally though? It's not natural. If I can take it natural, why can't I orally take it? I think that's where the back and forth play happens. And I always tell people, well, your stomach is made to dissolve and break down proteins. It's the same with peptides. So when you put it in your body, it's going to break it down. There's enzymatic reactions that happen to break down proteins. The same happen with peptides. They're smaller, which means they're easier to break down. Therefore, getting past the gut is very difficult. So I think trying to tell people to take BP-757 orally is not a hard sell for me. The second I say you need to inject it, we're in medicine, right? What does everyone think? Everyone thinks pills. I do believe that the GLP-1s, again, natural, have changed the game when it comes to longevity. I just went to a conference last weekend. In fact, I was there with your fearless leader, was there, obviously. And we were talking about this, and I said, this is the biggest conference I've been to my entire life. The conference was 2 to 3 times larger than the year before. Why? Peptides. I think we all understand. Most people here 2 years ago didn't know what peptides were, probably. And then GLP-1s brought peptides mainstream. So I think people are like, oh, if I'm injecting this, I can inject something else, right? I can maybe put some BPC in myself. Look, if I'm already injecting some GLP-1, I might as well inject some NAD too. Why not? Let's just add another injection to this. And I think the fear of injections has gone away, allowing people to be more open to doing the peptides. There were only bodybuilders. When I first started this, it was bodybuilders doing this. Convincing patients to do BP-757 was impossible. I'm like, it's natural. Guys, I promise we make it naturally. Just take the injection. Is there an oral version? And now people come to me and say, wait, do you have the injectable version? I don't want the oral version. What happened? God, people were saying no to this. And now people are begging me to get injections. I think it's hilarious. My patients are now like, oh no, I want the injectable. Don't give me the oral. That's not going to work. Give me the injectable. So there are a lot of natural peptides that exist. And I think we just have to remind people these are natural. The only reason we're given to you as an injection is most of these natural products can't get through your gut, which means you have to orally take them.
Great. Now, again, off script, methylene blue we just came out with. That's a pill. So how is
Mhm.
that different than
Yeah, how's the other peptide? Well, methylene blue is a dye originally, thiazide dye. It's used for methylmoglobinemia anemia. So basically, you can't let go of an oxygen molecule. It's holding on too tightly to the iron and it has to be broken off. And this is where methylene blue is needed. This is the on-label use of the drug. It's like the one thing that it's used for in hospitals. So many doctors, in fact, the reasons why Ellie is requiring everyone to get testing if you're in a certain, if you're African descent or Middle Eastern, all these things, they list the things you have to do to get the G6PD. The reason that's required is because in the hospital, when you go high dose with this stuff, it can cause some issues with G6PD. The dosing that Ellie is using is, I ain't told this to honey, but it doesn't matter. I'm not the doctor prescribing, so they don't consult me on this one, unfortunately. For 10 milligrams, I would not, 25 milligrams even, I would make a patient have to do this testing because at these low of dosages, you're not going to get hemolytic anemia. This is the fear. If you have this G6PD deficiency, you basically can get hemolytic anemia from oxidative therapies, things such as high dose vitamin C, ozone, methylene blue. They can cause hemolytic anemia, which means your red blood cells just split open and they just spill the contents out. That is not good. So, at the dosages we use at LEMD, the risk is about zero. So I don't want anyone to fear about this stuff. I am very, very concerned in my own practice. I'm not running G6PD at 10 milligrams of methylene blue. So I love methylene blue. It is not a peptide, it is a bit different. It is again a dye. So the reason we use this and able to get to the gut is because this one actually you can't inject. If you injected sub-Q or IM, God help you. It is so painful. It hurts. It's going to kill the tissue. You don't want that. IV I use in practice. I only use the IV if I have a serious infection. I'm not using it for the day to day. Anyone that's on methylene blue in practice is on oral. And because it can pass the gut, this is one of the few ones that can get past the gut. We have ways to move it past that because it's not a peptide. It doesn't have the amino acid sequence. It can get past the gut. That's the difference, right? Peptides can't get past the gut because they are amino acids. They're those building blocks. And we have ways in our body to break these down. We don't have that in our body. There's no way to break down methylene blue. In fact, if you take methylene blue, you're peeing blue. You see that your body is literally still holding on to it and it's pushing out as the same blue substance you put in your mouth. So yes, we cannot break down methylene blue in the gut, which is why it's totally fine to take as an oral pill because you're actually getting full use of it when you take it orally.
Okay, cleared up a lot. How about SSRI? Is that an absolute no if you're on it? That's a, yeah, it's a hard no.
10 milligrams, I could argue. 10 milligrams is a very low dose. I have seen, so unfortunately, I've seen serotonin syndrome. This is what we're worried about. Serotonin syndrome is the fear. If you're on an SSRI or SNRI, and you push too much serotonin out, and you add methylene blue, which is an MOAIA, which is monooxidase inhibitor A. There's an A and B of this. It increases serotonin very low. At 10 milligrams, the likelihood of you having an interaction with your Prozac or your Lexapro is slim. Now, if you are on the top dose of Prozac and you're on Wellbutrin, you're mixing and matching your SSRIs, yeah, I'm going to say maybe not the best. Add one more thing to that because your doctor who's prescribing this is going to be very confused when you come into the ER and you can't breathe. This is what serotonin syndrome does. I had this happen to me. It was very sad. They find she was fine, didn't die, but they end up in the ER. They got IVs. Now, this was the IV form, which is significantly higher than I'm giving any patient out there. So the only patient I've ever seen this with, they were on SSRIs. They were on it with methylene blue. They did not tell me that their doctor raised their prescription to the top dose of an SSRI they were on. So the IVs they did multiple times were fine. And then they finally got to the point they did the IVs, and unfortunately their son ended up in the hospital twice. Couldn't breathe, very bad. They didn't know what was going on. They couldn't figure it out. They traced it back to the days he got the IVs. This happened. And like, we give him, they knew this. And then he was on methylene blue, like, oh my gosh, interactions with SRIs. And he was getting a high dose of methylene blue. So we were doing 20 milligrams of methylene blue compared to 10 milligrams of methylene blue. Now, the oral amount versus the IV amount, we're getting 97% absorption. You're maybe getting about 60 to 50% absorption. So I was 4x giving this person this dose, and they were on the top dose. Very unlikely that anyone that takes 10 milligrams of methylene blue can have anything wrong happen with SSRIs. I will still say, check with the provider. I want to be very clear on that. Like, ask them if they're okay with it. But I can tell you now, there's so many biohackers out there that don't even know this. They're taking methylene blue, dropping their cups. RFK is on SSRI. Who knows? And he's taking methylene blue. Maybe he doesn't know this. RFK, if you're watching this, Make sure you are taking methylene blue under doctor supervision. But he's, go drop this. All sorts of people buying this, from fish food stores. They're going in and buying these droppers and they're dropping their cups. And most people do not know about this as the right thing. So I would say that realistically, 10 milligrams, very unlikely risk to be unnecessarizing in this unless it's a super high dose. But I still would tell anyone that's talking about this, hey, it is a risk factor to consider. And I'm not telling you to stop your SSRI, but I do have patients that have stopped their SSRI. I do say you've got to wait at least 4 weeks before you start, and then they'll actually start methylene blue and move their dosing up because they are having some mood support. Again, because it is an MOAI, you're going to see improvements in mood and anxiety, less depression, mostly less depression, these people. So it is being used for that right now. I've used it before in patients to reduce their depression symptoms.
Okay, great. And with last question about methylene blue, should you be always peeing yellow? Like time you pee, yellow, not yellow. You should be
Should be
blue.
yellow. I think if you're not being yellow, you got some more issues.
um,
Mm,
blue. I'm
yeah.
time.
Most do. I would say even at 10 milligrams, you're going to see some blue urine, maybe a greenish tint. You're going to have some blue. You are passing it through your kidneys. You are going to bypassing. It's going to right out of you. If you see blue in your feces and it's not in your urine, not doing what it's supposed to do.
Okay.
It's not working the way it's supposed to. So then I stop. So if it's in the feces, I have them stop because the pathways for metabolism are not working the way I want them to. It should be in the urine. You should not be pooping blue. And
Okay.
Smurf poop is not good.
But if it's clear, it's
It's
okay.
fine. If it's clear,
Okay.
yeah, some people, listen, it could be clear because you drank a bunch of water. So you can't
Yeah.
tell it's blue because you were super hydrated. I didn't see the blue. Well, how many water did I have? I don't know. I had 15 ounce glasses. That's a lot of water. You probably didn't even notice because you had so much. So if it's concentrated, yes. Most people on 10 milligrams see blue. Yes.
Okay. 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 A question. Do you recommend GLP microdose for life with all the
Mm.
benefits?
Let's go over what microdose means. This is where we
Okay.
get into some trouble. I recommend GLP-1s for life, period. I think they're great. What I do caution is this microdose. It's become a buzzword, right, in our community in general. Microdosing to me means microdosing, dose. So when I say microdosing, I'm talking about a 2.5 to zero point 0.5 milligrams of semaglutide. That's for me as a microdose. It's very low. For me, using a microdose of is 1 milligram to 2.5 milligrams. Again, low dose. These are still technically clinically effective dosings that you can use for weight loss. There's people I give 0.25 milligrams of semaglutide to, or have anyone out there has had it, and so I lost weight at the bottom dosing? Good for you. That's awesome. Microdosing to me is anything lower than the weight loss dose you're doing. Realistically, I don't see that as anything like taking milligram of say that's a microdose. I still have this like dosing range, but if you're losing weight at zero point 0.5 milligrams of semaglutide, I'm going back to 0.25 milligrams of semaglutide. I don't want weight loss with my microdosing. That's not my goal. For me, there's weight loss dosing and then there's like dosing. Longevity dosing is what I would consider microdosing. There are some people out there who are talking about microdosing as, hey, I'm doing zero point 0.1 milligrams of semaglutide. I'm doing 0.2 milligrams of tirzepatide. That dosing is going to offer zero long-term benefits. So microdosing, and what some people are saying is this small baby dose. At that point, just don't bother. Or the other one you have is people that are doing this every 14 days, right? They're like, I'm taking this like, but only every 2 weeks. And I want to tell people this was meant to be dosed weekly. The half-life is about 7 days for both these, 7 to 10 days. You want to keep the same dosing protocol. So if you want to do it every 14 days, great. Take the dose you're doing, divide it in two, and give yourself that dose every single week. If that's what you want to do. So make sure everyone knows it is a weekly dosing no matter what you do. It's always going to be weekly. If they want to do every 2 weeks, just go down and dose. Drop it in half and do that dose. So, yes, I think GLP-1s are great. There was this select trial that was done in the beginning of SAG when it came out. They found reduction of major adverse cardiovascular events, MACE, 20% reduction of cardiovascular disease. This is massive. They originally thought this occurred in obesity and occurred in type 2 diabetes. They just reanalyzed the study in the last month or two, and they showed anyone on a GLP-1. So this takes out anyone that's obese or anyone that's diabetic. We know this great. But you and I, or anyone else on this call here, if you are on this right now, there is going to be a roughly up to 20% risk reduction of cardiovascular disease by taking a GLP-1 long term. So if that's not enough to get people out there excited about this, I don't know what else to do. 20% risk reduction is absolutely amazing. So this does is it stabilizes the plaque. So we have two kinds of plaque in our body. We have hard and we have soft. Soft is dangerous. Soft is like, like silicone implants, like soft is squishy. Hard is a concrete stock. Put a piece of concrete down, stick it down, it's not moving. That soft can break off. That's just going to break off and clog your arteries and cause issues. There's actually two tests you can do for this, three, I guess. You can check your artery score. Basically, it's going to tell you, of artery score. Calcium artery score tells you how much calcium you have. Then there's a test called Clearly and Heart Flow. They're both CT grams. What they're going to do is tell you where the plaque is and what kind of plaque you have. So it clearly says where this piece of plaque is and how much soft plaque you have versus hard plaque. And heart flow tells you how much stenosis, basically how much has this artery squeezed down because of the plaque. So it can give you a good idea of what your risk factors of having cardiovascular disease are. And again, it doesn't matter because we have GLP-1s, but they're going to stabilize this soft plaque. The only thing that people understand is this soft piece of plaque won't break off because you're on GLP-1. It also lowers inflammation, which is also part of the reason why we build plaque. And it stabilizes blood pressure, which is another reason that we have issues because that blood pressure is going to push really hard and break off those pieces of plaque. So anyone on GLP-1 will have a risk reduction of heart disease no matter who you are. So yes, if you're on not taking a GLP-1 for life, you're missing out. Also, I forgot this other one, reduction of heart disease, cardiovascular disease and Alzheimer's. Alzheimer's, big one, liraglutide, the cousin to found a 20% year over year slowdown of Alzheimer's compared to placebo and
Wow.
50% more brain mass compared to placebo. So we know liver cirrhosis, psoriasis, whatever, you just name a condition, it's going to be GLP-1s.
That's okay. So then, like a flip on that.
Yeah.
So for Samorlin for stage 4
Which
is
one? I'm looking.
Jennifer. We can unmute you too, Jennifer.
Sermorelin and cancer. Is that the cancer question?
Well, it was the Sermorelin for the cirrhosis.
Oh,
He was
yeah.
3 months of it. Our provider approved it, and then now he's been denied, and they said no peptides for cirrhosis. And I'm
I'm going to
like, we
bang my head
already
against the
got it.
wall.
They even mailed it to us, and they want
Yeah.
it back because they said no. I'm like, he
So
felt good on the Sermorelin though.
is it, wait, is Ellie the one who took it, is taking it back? Yeah. So you have to remember, love honey. She has doctors group are the ones determining this. They're conservative. They don't know peptides that well. Not that they don't know them at all, but they're not educated. Like I've spent many years doing this. Like they ones who wanted methylene blue to be put on this, have G6PD because they're super worried about this stuff happening. They are super conservative. Sermorelin, Tesmorelin, CGC-1295 are all going to lower your cirrhosis. It is actually useful for this. It's not bad for this. But again, conservative. They're yes, because they don't want something bad to happen. They don't want it to get worse. So no. Is it going to get worse? No. But again, they're on the safe side and they don't know enough about peptides to even do that. And so they're trying to cover their own because it's a big doctors group and they have other telehealth companies that they don't want to see go bye-bye when something bad happens to a patient. And again, you're just one person. So they are not having a conversation with you like this. This is not how they work. They call on the phone, you get a little chat. Okay, you say go, goodbye. They're not doing synchronous care. Like what I do, synchronous care is following this stuff up. So they can't follow up if thing bad happens. They don't know what to do. They can't change the care because once prescribed, that's it. No, it's fine to use. I'm not upset about Sermorelin. Tesmorelin, all used for that. I would say it's totally fine, and I would use it in both of those.
Okay, thank you. Dr. Pencek, thank you so much for being on this call. Our time is up, and you're honestly, look at this. I've scratched 3 of these. That's it. So
That's
would
how
you
Honey and I, when she asks me
recommend
questions, it's the same thing. I get like 15 to go through like 6 of them. I'm like, well, you
it?
get the rest.
But it was just amazing. And you can follow what exactly on Instagram? Is it Dr. Jason Pencek?
It's
Dr.
just Dr. period Jason Pencek. And I post this stuff every single day. I'm making reels. I think today's reel will be on NAD. I did it. Normally, I don't pre-make videos. This is like for me, I'm trying to start like being, but I have to like come home and be like, what's my video today? So I post on something every single day, health space, hormones, peptides, exosome stem cells, you name it. I'm posting about it. Whenever you ask questions and it's interesting to me, I might make a comment and make a video on it. So if you want anything health related, I'm posting every day. I teach on this stuff worldwide. I teach on peptides, hormones, and other stuff. So if you have any questions, I also answer my DMs. I'm very, very, I don't bite
So
too
friendly.
hard. So if you have any questions, reach out to me, ask me anything. If you don't get an answer from me, I typically just need a second message, but I do respond back to almost everyone that says something to me and every comment. I spend hours on Instagram and get yelled at for this because I do spend a lot of time. Again, I want education to be free. I want everyone to get the education they need because these are questions. If you have a question, there's probably 20 of the people asking the same question as you and wondering the same thing. So
Yeah. Yeah. Thank you so much. And thanks for
you're
everyone
welcome.
joining us. Hey, everyone, have a great Christmas.
Enjoy. Thank you so much. Have a good one, everyone.
Thanks, you guys. Bye-bye.
Bye, gang.